Hi, and welcome back to the symposium. I'm Kim Frederking, and I'm grateful to be joined by Dr. Mike Ortiz from Memorial Sloan Kettering Cancer Center. This is an important session about a very tough topic: what happens if my child relapses? Many of you are already familiar with Dr. Ortiz, but if you'd like to know more, please check out the virtual program to see his full biography. Welcome, Dr. Ortiz.
Hi, and thank you so much. My name is Michael Ortiz. I'm a pediatric oncologist at Sloan Kettering, and I'm really appreciate the opportunity to speak with all of you. This is a different audience than we normally get to speak to, so I'm excited to have this opportunity and thank Elevate and KCA and the Morgan Adams Foundation for hosting this event, which is really, it seems really tremendous. Next slide. So I'm going to talk about what to do, or what we think about when a child with Wilms tumor has a recurrence of their tumor. And it's helpful, I think, to set the stage for sort of why we are where we are. And for many of you, you don't really get a history lesson in how we got here. And so this very quickly goes through the history. So until around 1970, there was no organized management of Wilms tumor. And around that time is when both the National Wilms Tumor Study Group and SIOP in Europe launched their separate consortia. A few years later, we realized that children with Wilms tumor started to have late effects from the chemotherapy that we were giving them. We developed a recognition that anaplastic Wilms was a different one, and then subsequently started treating them differently. And by the 90s, we settled on regimens that are still the standard of care: EE4A, DD4A, which many of you may be familiar with, where we gave chemo over 1 day instead of 5, has been around since the early 90s. And the neoadjuvant chemotherapy that's used in SIOP with 2 or 3 drugs over 4 or 6 weeks has been around for now several decades. And as I'll talk about a little bit on the next slide, the remaining therapy is really focused on how we risk stratify patients. And the reason for that is that initially the treatments of Wilms tumor was very successful, and perhaps much more so than other pediatric solid tumors. By the early 80s, we were curing almost 80 to 90% of children with Wilms tumors, which in contrast to sarcomas and neuroblastoma was much, much better. And so as a result, the majority of the effort over the last several decades has really focused on risk stratification rather than development of new therapies, which I think is understandable, but it puts us in a challenging situation when we think about what to do with children who've relapsed. And click again. The reason being is beyond the need for better therapies for children who relapse. Even, it sounds like, as you guys were hearing about in previous talks, the prevalence of chronic severe health conditions in children with Wilms tumor is very significant. And without novel, more effective therapies than chemo, surgery, and radiation, we're sort of not really able to meaningfully address this. Next slide. So this is a paradigm of, this is how I think about newly diagnosed children with Wilms tumors. In general, we are good at curing most patients. And in order to figure out how much therapy to give an individual patient, we generally target somewhere in the order of 9 out of 10 patients being cured. And that tries to cure the most patients with the least amount of side effects possible. I like to think of each new patient with Wilms tumors as sort of, how far up the stair do I need to have them walk in order to give them the best chance of cure with the least amount of toxicity. And things that we think about include their age, the biology of the tumor, the histology, the stage, adverse biological markers. And then there are other factors that we certainly consider. And this kind of goes to show you that as we have more and more aggressive features, we add in more drugs, we add in radiation, and you can see sort of this paradigm. Next slide. So sometimes, though, about 1 out of every 10 children that we treat will relapse with Wilms tumor, and that's devastating. And I wanted to share some hope, as well as a paradigm for thinking about relapse in Wilms tumor. So next slide. So this slide is shared with permission. I guess it didn't come out perfectly. Can you click once more? Okay. Well, anyways, it's a little bit of formatting issue, sorry. So Colin was a patient who I treated after his second relapse. He was very appropriately treated in the upfront setting and the relapse setting. And he had a lot of complications coming into the second recurrence. When I saw him, he was dealing with some infectious complications still at that point. But we were able to get him into remission with some chemotherapies that his tumor hadn't seen, surgery, radiation, and a transplant. He enrolled on a phase 1 study, and click again. Colin's now more than 5 years post-transplant, doing great. And you can click or next. Yeah. At the time, I truly didn't believe that it was realistic that he could be cured, but I was very happy to see him now, many years later, thriving. And so there is some hope, even for some of the hardest to treat patients. But obviously that doesn't always happen, but it's helpful to sort of understand what you're up against. So next slide. So when we are caring for a child with relapsed Wilms tumors, you should know that the current paradigm is to split patients into 3 different risk groups. One of them is called standard risk, one of them is called high risk, and another one's called very high risk. Standard risk is generally patients who relapse after EE4A or other 2-drug therapies. High risk is patients who relapse after 3-drug therapy. And very high risk is kind of anything beyond that. So multiple relapses, high risk histology, or 4 or more relapses. Majority of patients are high risk relapse, or about half, with about maybe a quarter each of standard and very high risk. Most standard risk patients can be cured. It's about 50-50 or so for the high risk patients, and very high risk patients, it's on the order of 10 to 20%. Now, those numbers are probably not totally accurate, but that's the best information we have right now. There are many other factors, such as the timing, the sites of relapse, the biology of the tumor, the prior toxicities that contribute to how likely a child can be cured. But those cure rates also were reported, really from decades ago. The topoisomerase 1 inhibitors were developed in the early 2000s, so things like irinotecan and topotecan, and the last relapse Wilms tumor trial was actually the National Wilms Tumor Study 5, which is from the late 90s. Both ARI in 1921 and the current SIOP umbrella study don't have published data. So I suspect that there will be in the future a better way of risk stratifying Wilms tumors, but we don't have that now. Next slide. So the current standard of care for these on COG is to use UH3, which is cyclodox-vinc, cyclocarboetrope VI. For standard risk, in the SIOP approach, it's dox and cyclophosphamide alternating with carboetope. For high risk and very high risk, it's ice-cyclotopo for COG. For high-risk patients in SIOP, they use ice and cyclocarboetope, and then either repeat those with another 4 cycles or they do an auto transplant. And for very high risk on the SIOP regimen, there's actually no specific guidance, although they do recommend the use of topoisomerase 1 inhibitors like irinotecan and topotecan. Next slide. Next slide. it's important for families to understand the different stages of clinical research. When we talk about developmental therapeutics, which hopefully some of you have heard of, that generally refers to phase 1 and phase 2 studies. Phase 1 studies would be often first studies to evaluate how a new drug is given and what's safe. So usually first in children's a phase 1. Next slide. A phase 2 study would be seeing how effective a drug is in a specific histology like relapsed Wilms tumors, more patients, and it's particular focus to see how effective it is. Next slide, or click again. So phase 3 is trying to figure out if this seemingly effective therapy is better than the standard of care. That would be, for example, like 2231 trial that's ongoing. And then next, click again. So phase 4 studies would be a post-marketing analysis, which is actually quite uncommon. Next slide. Again. Yeah. So with most early phase trials, we use a system called RECIST to define whether or not a treatment's effective in shrinking a tumor. And so the way RECIST works is that you measure up to 5 lesions, each measuring at least 1 centimeter, or if it's a lymph node, 1.5 centimeters, and you take the sum of the length of the diameter of those lesions as your baseline total. That's called the SLD. And then you identify all the smaller or what we call non-target lesions. And then the goal is obviously to make all the tumors go away with no lesions come back. That's called a complete response. What is more often achievable is to shrink the tumors more than 30% with no additional lesions showing up. That's called a partial response. Stable disease is when it doesn't grow or shrink. And progressive disease is when there's new lesions that show up, or if the target lesions grow by more than 20%. And when you're reading papers about how effective a therapy is, often we talk about objective response rate, and that's the percentage of patients who have either a complete or partial response. Sometimes you'll hear disease control rate, and that is basically includes stable disease. So it's basically how many patients didn't progress on the study. Next slide. But the reality is that historically, outcomes for phase 1 studies in pediatric oncology in general have not been great. There was a study that looked at almost 110 pediatric oncology studies from 2012 to 2017. In that study, although many of them included targeted therapies or drug combinations, about 12% of patients had what's called a dose-limiting toxicity, which is a side effect that we a priori define to be too much to give that drug. And actually 1 in every 200 children died on the study. And in all of those trials, almost 40% of the trials didn't have a single patient that had any objective response, whereas only 17% had more than a quarter of patients who did. General targeted therapies have had better response rates than those with cytotoxic chemotherapy with similar objective responses. Next slide. And frankly, outcomes for Wilms have been perhaps even less. There was a study by Jesper Brock in the SIOP group when he looked at a 20 years worth of early phase trials across 257 Wilms tumor patients, almost all of which were very high risk relapse. Only 9 of those trials actually had 10 or more Wilms tumor patients. Several of them included drugs that you're familiar with, like irinotecan and topotecan. And if you exclude the conventionally known to be active chemotherapy drugs like dactinomycin and the topoisomerase 1 inhibitors, there's actually only 3 patients out of that whole group that had an objective response. And as a result, there's no approved molecularly targeted or immunotherapies for Wilms tumor right now. And that's the focus of my research. Next slide. So how do we identify new therapies? So there are preclinical consortia there are consortia that are focused on trying to evaluate novel therapies, the PEP-CTN being probably the best known, and that's the COG's DVL Consortium. It's led by Beth Fox out of St. Jude and Jenny Foster out of Texas Children's. It includes 44 sites. Right now there are 3 trials that are I think potentially relevant for relapsed Wilms tumors. I'm leading a trial of a drug called Enhertu, or trastuzumab deruxtecan, that will hopefully open up this summer. It's already open for osteosarcoma, and we're amending it for Wilms. Sarah Whittle and Joe Pressey have a trial of a pathway inhibitor called tegavivint that's about to be done, and we'll be completing soon. And then I have another trial that uses standard dose irinotecan with an apoptotic targeted therapy called DT2216. That's not specifically for Wilms, but obviously is relevant for Wilms tumor patients given the sensitivity to irinotecan, which is currently not accruing. Next slide. Outside, so there are many different disease-specific consortia that do not exist for Wilms. So for neuroblastoma, they have NANT. For leukemia, they have TACL. For brain tumors, they have PNOC. But we don't have anything like that for renal tumors. I've been trying to create sort of a high-risk preclinical or a early phase clinical group through a consortium called PPOC. And in several of my trials that are not in PEP-CTN are through PPOC. And then there's some other organizations like Poetic, which previously out of Memorial and now is based at Stanford, and the Sunshine Project, which is based down in Moffitt, that are more histology agnostic and could run trials like this. And then, of course, there are, especially for some of the CAR T-cell studies that we'll talk about, are often run in single institutional studies. That limits access, but often it's necessary for drugs like CARs that require certain processing. Next slide. So these are a lot of the focus of current clinical trials. I'm not saying future, but at the moment. I mentioned tegavivint. I think some of you are aware of, I'm running a phase 2 trial of selinexor, which is an XPO1 inhibitor through the PPOC Foundation, PPOC consortium. I mentioned BCLXL, which is an anti-apoptotic target that we are targeting with through the PEP-CTN, as well as Enhertu or trastuzumab deruxtecan. Some other targets that people may not know as much about, Claudin-6 is a target that's relevant for some Wilms tumors, and we have a study that's open, but we were at the moment only able to evaluate 12 to 17-year-olds. It's really intended for older patients. So that is unfortunately limiting for many Wilms tumor patients. Glypican-3 is present in most, but not all Wilms tumors. There's a CAR T-cell study out of Houston, and I think soon, if not currently, is available in Seattle. And the PPOC group has a GPC3 directed antibody that I'm running. The Seattle group also has a CAR directed at EGFR, which is relevant in some Wilms tumors. And then there's actually quite a few B7H3 CARs. Seattle, St. Jude, Stanford. I think St. Jude may have just closed theirs or finished the study. And I know Dana-Farber will be opening their trial soon. It's the same group from Stanford that's now out in Boston. The SABRE trial out of Children's National is also a B7H3 CAR, but it includes PRAME CTLs, and they have some other trials that are forthcoming that hopefully in the next several months to year will be available. Several of these are my trials, so I'm just trying to be transparent that the starred ones are ones that I'm leading. So next slide. So I think the reality is that we now actually have a lot more novel therapies that have specifically focused on relapse Wilms tumor, but it's still, no one's believes that where we're at is good enough. And so, as much as I'm hopeful that these therapies will be the cure-all, I think we recognize that it's still really important to advance laboratory-based research in Wilms tumor, both to try to figure out if any of these work, to intercalate them into the existing framework, as well as if they aren't effective, try to find something better. So next slide. So how do we do that? So a lot of that comes down to laboratory testing, and obviously there are individual labs, but the two biggest pediatric preclinical testing consortia is called the PIVOT group in the US. And you'll note that the way PIVOT works, there are each center has a particular disease focus. So, for example, CHOP, they have a particular focus in neuroblastoma. MD Anderson has a particular focus on osteosarcoma. And we and the UT San Antonio group are the ones that focus on kidney tumors, and so have a particular emphasis in terms of the development of preclinical models and preclinical testing. Click again. In Europe, there's something called the ITCCP4, and that's actually a public-private partnership. They have, I would say, a different setup, but it's similar in that they do a lot of both preclinical testing, and they also are interconnected with the clinical clinical trial infrastructure and do run some trials through that group. Next slide. So unfortunately, because of cutbacks to the NCI, Pivot will lose its funding in June. And so there's no plan to continue that. The only other large group that I'm aware of that's kind of in this space is called Proxy. Proxy is a little bit different than Pivot in that Proxy is more of a federated preclinical model where basically all the groups say, okay, we'll just do things the same way. And if a company or an investigator wants to do certain testing, they can do that and across multiple hospitals or as multiple labs. And in this entire group who's listed here, they have 64 different validated, like genomically validated and expanded Wilms tumor xenograft models. So even rare Wilms tumors we have, and I certainly make an effort to generate models on my patients' tumors, so to build up that repository. So it's particularly enriched with relapsed and higher risk tumors. Next slide. So in summary, if your child has a Wilms tumor or suffers a relapse of his or her cancer, it's important to understand that there are both conventional novel approaches that may be reasonable. I just wanted to share a couple of patients of mine, Colin before and Joshie here, that are really hopefully give some inspiration and hope for those of you who are going through this right now. Next slide. And I would just thank Elevate and KCA, the Morgan Adams Foundation, the Comer family. I think finding safer and more effective cures for Wilms tumor is definitely the key. Next slide. And I just have to acknowledge that Wilms tumor, while important to us, is not a major health consideration for government or pharma. And so almost all of the money to run the trials that I run is paid for with philanthropy. We do get a very limited amount from drug companies. So I'm running several different trials. And I'd say, with the exception of PepCTN and the organizational framework that's government funded, the vast majority of the research that I'm doing is paid for by foundations, family members who've directly donated, and friends, and so very grateful for the opportunity to move science forward with the help of all of those of you. So, because unfortunately, that's the current paradigm that we have right now. I think that's it. Oh, my last soapbox is that, look, if your child has a high-risk cancer, especially if it's a relapse cancer, make sure that you see someone who sees these types of cancers. Certainly doesn't need to be me, but it should be someone who has some expertise in this space. And it's usually helpful to get a second opinion early. Sometimes I get second opinions very late in the disease progression, and would have preferred to have been able to try to help earlier on. I would just encourage you to seek second opinions early with any high-risk cancer. I think that's all. So I'm happy to take questions. It sounds like Kim was going to facilitate that.
Yeah, you did such a great job. We have almost a minute left. We have 15 minutes of questions, 15 minutes of time available for questions. We have 3 open questions in the Q&A, and I encourage you to type in to the Q&A if you have any additional questions. Our first question is, can you talk about older adults being diagnosed with Wilms and reoccurrence after 2 years of being cancer-free and 14 years of being cancer-free? This woman mentions she was diagnosed at 32, 35, 54, and now re-diagnosed with Wilms at 55. Go ahead.
Yeah. So it sounds like Nick a little bit touched about on that. So there are distinct entities called older onset or adult onset Wilms. I have a particular interest in this, and we've been doing a lot of clinical and biological work around this space. The sense is that there's probably different underlying biology causing patients who have older onset Wilms tumors. And we do know that it's well established that older onset patients have worse outcomes. Our belief is that that is due to both clinical and biological factors. Historically, it's always been attributed to delays in identification, the intolerance of vincristine, higher rates of anaplasia, but I actually think it actually at least as much has to do with different biology. I don't think a 32-year-old who developed Wilms and a 2-year-old who developed Wilms develop them in the same way. So there is also a separate condition, which Jeff Dome calls chronic or late relapse Wilms. That's different. I guess in your case, this is perhaps the same thing, but typically most Wilms, when they recur in the first 2 years, rarely after the first 4 years. That's why you often hear us present 4-year event-free survival. But I have taken care of patients who have relapsed multiple 20 years later. That is very, very uncommon, but it can happen. Because those late recurrences beyond 10 years are so rare, those we don't have good understanding of the biology of. And certainly an adult with a late recurrence, there is definitely not a lot of information on that. We, in the biology series that I'm running, we have about 125 older Wilms tumor patients, which was quite a challenge to collect all of those to sequence. But we certainly do not have serial sequencing on late recurrent adult Wilms. That it would be of interest, but not. I wouldn't be able to tell you the mechanism there.
Okay, thank you. Our next question, do you have any knowledge of the use of paclitaxel for diffuse anaplastic Wilms tumor relapsed stage 3?
Yeah, so I was part of a group that recently put together a case series of patients with treated with paclitaxel. It was a kind of a hodgepodge group where everybody put together their experience with using paclitaxel, the combinations, and the general sense is that paclitaxel is active. We've actually known that for a long time. There was a study back in the late 90s that showed that it was never published, but we knew that paclitaxel was active. Other taxanes haven't yet shown activity, but paclitaxel and I guess nab-paclitaxel have shown activity. What we don't yet know is what is the best combination to use. There's some consideration of gemcitabine, particularly for anaplastic Wilms. Jeff's paper, and I guess it's Alyssa's paper too, suggested that paclitaxel with doxorubicin was a promising combination, and I personally have used it more with topotecan, but I don't think that we yet know what the right way to utilize paclitaxel is, and or whether, for example, in a recurrent anaplastic Wilms, how that compares to conventional therapies that we would use, for example, something like ice.
Okay, thank you. Next question is ctDNA something to encourage our oncologist to monitor during treatment?
So I was very excited about circulating tumor DNA when we first started to have access to it about a decade ago. I was using it quite regularly, and I was a little underwhelmed with what I found. It didn't seem to do better than scans. What I can share is that the technology has improved dramatically over the last decade, and now there is a very concerted effort to utilize circulating tumor DNA in a research, not a clinical context. We are working on trying to develop a minimal residual disease assay, and we're collaborating with Dr. Mullen and Dr. Crompton at Dana-Farber, and they're trying to work on an early classifier looking at both response to therapy and diagnosis. And so what I'd say is I don't think if your oncologist isn't sending ctDNA that is the wrong thing. I think if they are, that's interesting, but I have sent it many times and rarely have found it to meaningfully change what I'm doing yet. My hope is that in the next few years, that will be different as the technology improves. And I expect that, let's say, definitely 10 years from now, I will hope that we will be incorporating ctDNA better into the way that we treat patients. We are banking it in all studies. And for certain pediatric solid tumors, for example, Ewing's, it is now starting to be incorporated into risk stratification. So I think we're close, not quite there yet.
Thank you. So this speaks to this is an international question. In general, are clinical trials available to Canadian patients or anywhere outside the United States? If so, can they be done from their regional or regular hospital overseas?
So until very recently, Canadian hospitals were included in the PEP-CTN. With recent changes at the government level, it seems like that hasn't been as accessible to them. I don't know where that will land. So there are definitely consortia that do include, like, for example, Poetic, I know, includes Canadian sites. And even preclinically, like Pivot includes an Australian site. So there is still some overlap, maybe a little less than previous. So it would be nice if we could incorporate. The challenge has to do with the cost. So if a drug company were to try to get this through in Canada or Australia, New Zealand, it's much more expensive and so if they aren't required to do it, there's less of an incentive to do it. So that's one of the challenges with it. It's actually just more expensive to do, and in general, the number of patients isn't a lot. It's not to say those patients are also very important, but it is an additional hurdle that Canadian and other patients face. Your question about could you just do it at home? Well, it would depend on if the drug is accessible to you. So if the drug is only available through a trial, like, for example, a CAR, then there's no way for you to get that. You would need to come get the drug. Some drugs, often actually drugs that we use are used off-label because rarely are drug companies developing drugs specifically for Wilms tumors. And so if you can access the drug and your oncologist feels like they are comfortable doing it, there's no prohibition against it. You wouldn't be contributing to the knowledge of that one way or another. But I think that may be a reasonable decision to make, depending on how comfortable they would be in using that medicine.
Thank you. We have three more questions left in about 5 minutes. I'm going to try to get through these quickly. How do you decipher between metacronius Wilms tumors and true relapse in syndromic children, especially when the tumor reappears in the same location after a CR with neoadjuvant chemotherapy alone? I'm not a doctor.
Um,
And no surgery, and is now growing on baseline therapy, EE4A.
right. So the normal way that you would tell between a recurrence and a metachronous tumor at the same location um, would be to sequence them and to be able to tell. But if you had a CR in the beginning, you may not know. You presumably don't have any tissue unless that lesion was biopsied prior to the CR. So this is actually an example where ctDNA probably could have been helpful in retrospect. Not that I have been regularly doing it, but if you had a CR and you knew what the mutational profile was at diagnosis and you could query it, you could probably distinguish whether or not it was identical or not, assuming you collected any DNA from that. It may be hard to know. It would be very unusual for a completely necrotic, and I'll just distinguish. CR means the tumor shrunk and went away. Completely necrotic means you took it out and it was 100% dead. Those are not identical things. But if what you're saying is that the tumor was resected and it was completely dead, then you don't have any tissue. But those very rarely recur. So this is a hard question without knowing a little bit more information. But oftentimes when there's a question of whether it's metachronous or a local recurrence, sequencing can help distinguish those two things.
Thank you. I'm gonna ask this question, although I'm not sure it can be fully answered at this point without more information. But for a child with stage 1, under 2 years old, favorable histology with no genetic component who underwent EE4A, can you determine the risk of relapse?
So by no genetic component, I think you mean no predisposition. The piece of information that wasn't included there was the biology. So that prompt didn't state whether or not the tumor had LOH1p16q, whether or not there was 1q gain, and also whether or not the tumor had epithelial predominant histology. So it's hard to give an exact number without that information, but it's very low risk of recurrence. It's not 100%, it's not zero, but it's very low risk of recurrence. But I need to know those other factors to be able to give you a more precise number.
We have 3 additional questions. 2 are a little bit more detailed. But the last one I'm going to ask, because I think this is a question that a lot of people ask, how do you ask your team for a second opinion without them being offended?
I actually think it should come, if you are feeling that way, that's really concerning. Most of my patients, so often I am a second opinion, but when I'm not a second opinion, I encourage my patients to get a second opinion. And the reason for that has to do with, as an oncologist, there's a lot of weight to the fact that your decisions impact the life of a child. And I never want to get that wrong. I never want to miss anything that could help someone. So if someone else knows something that I don't know, I really want to know that, if that could help this child. And often, because I see a lot of kids with Wilms, I might be able to help a different kid. Maybe the thing that they're teaching me about that one patient not only could help the way that I manage this patient, but it would help other patients. So in general, it's a little bit concerning if your oncologist pushes back. I think to answer the question more frankly, I think if if you want a second opinion, you should feel empowered to say, I I appreciate the recommendations, and I think my husband and I were speaking, and we think that it'd be good to get another opinion. I mean, a lot of what people will do is they'll say, "Oh, my aunt says I should talk to so and so," but the reality is, you should be able to have a frank conversation, saying, "What you're saying makes sense. I think we would feel better about this situation if we got another person who could weigh in and see if there's anything else that they could do. I just want to make sure I'm doing right for my child." And I can't imagine any oncologist who would feel negatively about that. It's so common. I mean, I guess we're in New York where there are lots of opportunities to get second opinions, but I would hope that no one would ever push back. And that, frankly, would be a little bit of a red flag for me.
Okay. Thank you, Dr. Ortiz, for your time and expertise in the work you're doing in Wilms tumor and to advance research in this area. Appreciate it. And thank you so much.
Thank you.